So module V, let me get back to my slides. All right, so module V, we're going to talk about pain. I know we talked about it a little bit when we were talking about vital signs, because some facilities will consider pain the fifth vital sign because of its importance. Pain is, we're going to talk about what is pain, what is our role as a nurse aide in pain management, because like we said, we're not given medications, but there are a lot of other things that we can do to help manage pain. Pain is defined as anything the patient says it is, occurring whenever the patient says it does. What's important to remember is that the healthcare team does not define a resident's pain. The most widely accepted symptom of pain is self-reported. So believing what the patient says will lead to more effective evaluation and treatment of the pain. And there are so many different words that patients can use to describe pain. So I'm not going to read through all of these, but these are just a few. Again, there's a lot more. Something to keep in mind when you ask somebody about their pain. So let's say I come in and I say, Bob, how is your leg feeling today? Could you describe your pain to me? Is it aching? Is it dull? Is it radiating? If you do that, guess what? Bob's gonna be like, oh yeah, it is. It's aching, it's dull, and it's radiating. Let your patients have a chance to describe it themselves before you kind of lead them in any direction, okay? So I'm gonna say, Bob, could you describe your pain to me, please? Like what you're feeling right now? And then you get to use your silence, right? Let him describe it. Now, sometimes patients do have a difficult time describing pain. So I will allow for some silence. I will give them some time to describe it, but then I might throw out just a few words and try and so I would say, okay, I understand that sometimes it's hard to describe, Bob, but would you call it, more of a sharp or dull pain? Is it more achy or stabbing? I might throw out a few words and then help to kind of guide, but best case scenario is that they describe it in their own words without us kind of contributing. So facts about pain. Pain may sometimes come with aging, but that doesn't mean that we have to live with unrelieved or unmanaged pain. And it's important to know that pain is significantly underreported in nursing facilities, especially among the oldest of the old, females, minorities, and cognitively impaired. So although pain can be relieved in up to 90% of cases, a significant number of nursing home residents receive inadequate or no treatment for their pain, and that's just sad. In nursing homes, 71 to 83% of residents experience pain, and up to 80% of those residents who experience pain, it's interfering with their activities of daily living and their quality of life. Caregivers, including nurses and nurse aides, commonly underestimate pain. We have a tendency to underestimate pain. That's why the pain is what the patient says it is. Underrating and undertreating pain can be considered neglect and negligence or even abuse, okay? That's why when, the state evaluators come to check out a facility, they ask a lot about pain. If they find that all their residents have this untreated pain, that facility can't be fined or faulted. Nursing homes that do not manage pain properly will be cited, I jumped ahead a little bit there, with a deficiency by long-term care surveyors. They gather this information by interviewing nurse aides and the residents about how their pain and how it's treated and managed. So our reactions to pain can be different, right? So religious beliefs and cultural traditions may affect pain. For example, men and women may report pain differently. We shouldn't take these differences into consideration. Families sometimes will worry about drugs, the side effects or addiction or dependency. Some patients might not report pain just because they feel like they're bothering us, right? So we need to take these things into consideration so that we can better manage them. Staff's religious beliefs and cultural traditions may affect also how they view and manage a resident's pain. A resident might be in pain, but a staff member doesn't recognize it or believe it should be treated, and that's a problem, obviously. And then, of course, there's the opioid crisis, and there's a lot of fear about becoming addicted to opioids, and understandably so. But that is something that you could get the nurse to educate the patients about. because there is a time and place for medications when it is needed. So again, if a patient needs and family members need some education, go ahead and reach out to your nurse. So there's two different types of pain that you need to know the difference between for your test. There's acute pain and there's chronic pain. Acute pain is temporary. It can last for anywhere from a few hours to at most 6 months. That's the key there. A few hours to at most 6 months. If it's 6 months or under, that is still considered acute pain. Acute pain usually comes on suddenly as a result of disease, inflammation, or injury, think a broken bone, and then it goes away when the healing process is complete. Acute pain, it serves a purpose, right? It's warning us that the body has a problem that needs attention. So identifying and treating the cause of acute pain is usually possible and easier to do. When people are in acute pain, their discomfort tends to be obvious. Again, think of the broken bone. So acute pain can actually rev up the body and may cause pale, sweaty skin, an increase in heart rate, respiratory rate, and blood pressure. Now, when we're talking about chronic pain is, it's considered chronic pain when it lasts for 6 months or more. Okay, so under 6 months, acute, 6 months or more is chronic. Chronic pain often comes on gradually. People may have a hard time pinpointing exactly when it started, and this is when people tend to have a more difficult time describing the pain to others. The thing with chronic pain is it serves no purpose because it's continued after the healing process is complete. All of these things make diagnosing the cause of chronic pain difficult, and sometimes the chronic pain will continue despite treatment. When people are experiencing chronic pain, the source of their discomfort is not always obvious to people looking from the outside in. So these people might just appear depressed. Their body slows down, and this is a cause of chronic pain. Chronic pain causes our body to slow down. It causes decreases in both our heart rate and blood pressure. So again, we have to think, what is the reason behind the behavior? Could some of these behaviors be related to chronic unrelieved pain? Go ahead, Cheyenne. What do you have to add?
Like arthritis.
Yes. Oh, sorry. Yes.
Pain.
Yep, absolutely. Arthritis is a great example of living with chronic pain, where it's just going to slow people down, and obviously they're not functioning as well. They might start to not go out as often. So just something to be aware of. Now, speaking of arthritis, some common causes of pain that you may see: arthritis, cancer, osteoporosis, neuropathic pain, which is nerve pain. Pain from urinary tract infections, from ulcer diseases, physical therapy itself, pressure sores, wounds, or dressing changes. Phantom pain. Has anybody heard of phantom pain or have a guess at what phantom pain might be? Go ahead, Cheyenne.
Amputated limbs, and they're feeling the pain from that.
Yeah, so is that pain real or is it just imagined?
It's a mental pain.
But is it real?
To them.
Yeah, so it is real. It is, yeah. So phantom pain is real pain. Do we treat phantom pain? What do you guys think? Okay. Well, then I would say that's probably not the right way to go about it, based on what we know. So phantom pain is true pain. Think about, you've got all these nerve endings that go down your legs into your toes. If you get amputated, those nerves are all still there. So even if I've lost my foot, but I still feel that I have pain in my foot, that's not no longer there. That pain should be treated like any other pain. So whether that involves medication or therapy or whatever it might be, phantom pain is real pain and it's treated as such. So pain can have a lot of effects on people. It can cause people to give up hope, be depressed, have anxiety, withdraw, If we're in a lot of pain, it's going to decrease our activity and appetite and make it difficult to sleep. A lot of people with pain will feel restless and agitated. They won't want to participate in socializing or activities of daily living or their treatment programs unless that pain gets under control. It may even lead in extreme cases to thoughts of suicide or attempts of suicide. When we live with chronic pain, it actually over time is going to affect our immune system as well and weaken it. And when we have a lot of pain, it may put us at higher risk for injuries, falls, or accidents. So the nurse aide is often going to be the one a lot of times reporting complaints of pain to the nurse. So the nurse is going to be the one who then comes in and assesses and medicates as appropriate. But nurse aides play a really important role in pain management. Not only are we reporting complaints of pain to the nurse, but we're, again, the ones at the bedside most often, and most often going to be the one who notices when a resident is acting differently or showing the slightest signs of pain. Also, our personal relationships, those trusting, good, solid relationships with the resident, can be really helpful in pain management. And therefore, we do have an active role. We know that we want to control and alleviate pain whenever possible. And there are certain times when we want to make sure that we're always asking about pain and discomfort. So when we're doing personal care, when we're transferring or ambulating, getting them dressed in the morning, following any activities, those are times to evaluate pain. Also, if we've done kind of therapy, like a hot treatment or a cold treatment, after that's over, it's really important at that point to ask how effective it was. So how was the pain management? Did it work? Did it not work? So we can ask, different questions. Are you in any pain? Are you uncomfortable? It's really important to ask, where is the pain? Sometimes having them point to it is helpful. We also want to know, how bad is the pain? Depending on your residence, you may be able to use the 0 to 10 numeric scale. Say, all right, Mildred, how bad is your pain on a scale of 1 to 10, or 0 to 10, I should say? 0 is no pain at all. 10 is the worst pain imaginable. If the number scale is difficult for your resident for whatever reason, there's the faces pain scale where it has the 5 different faces that start from smiling to crying, and that might be something that's helpful for your patients as well. Some other good information to gather is, what were you doing when the pain started? Is there anything that you do that makes the pain better? Does this pain come and go, or is it constant? Have you had this pain before? So I know I just said a lot there. This is in your text. It's screenings of pain. It's slide 17 in your text. These are good questions to start getting in the habit of asking. If we just ask, are you in pain, and we leave it at that, that's good information, but we can get so much more information by asking just a few more additional questions. All right, let's see. Some of the comfort measures that we can offer as nurse aides is supportive talk, gentle touch, music, really decreasing the stimulation in the room as far as lighting and noise, the warm and cold packs, and they do have to be approved by the nurse, but this is something that we can do. Repositioning is huge, massage, soothing activities, prayer and spiritual support, if we're asked, listening and conversation, offering favorite foods or drinks, helping with hygiene, reminiscing, taking a walk. These are all little things that we can do that have a big impact on pain management. So if we're caring for a resident who is cognitively impaired, and when we're talking about cognition, that's their ability to think and process, okay? So if someone is cognitively impaired and they're in pain, a lot of this is going to be observing for signs of pain. In order of frequency of occurring, most people, when they're in pain, a lot of people are going to have changes in facial expression, like grimacing. They'll become restless with their body movement. Their typical behavior may change, so based on that individual. You may hear moaning, their muscles are going to be tense, they may actually become agitated, and in some cases with the cognitively impaired, they may become combative or angry. We definitely need to report this to the nurse immediately, and if we find something that works, make sure to share it with the rest of our coworkers. right, let me see here. Does anybody have any questions about pain and how our role as nurse aides in pain management or helping to report or treat pain? Any questions or any examples? Okay. All right, let me stop the recording on this one. You guys, we're going through a lot of lectures today. You guys are doing great.